Phil, I understand heel pain is the #1 foot pathology. Specifically, you're going to tell us a little bit about plantar fasciitis.
Yes, that's correct, Bruce. If we look at this picture here, we'll see the common area of pain is underneath the base of the heel. And the common term medically is plantar fasciitis, which means inflammation of the plantar fascia, but more at the base or the origin of it. What patients normally complain of is a pain that initially can occur on rising, whether it's getting out of bed in the morning or sitting down for a long period of time, then standing up quickly. What happens is they get a sharp, piercing pain underneath the base of the heel, much like a stone bruise. They tend to hobble around for a few minutes and then the pain seems to disperse and go away. However, if they sit down or lie down, the next morning it occurs again. Now what happens here, I say to a lot of people, when you're in bed lying down, your foot is actually in a relaxed position. Your arch has no strain on it. And we all know medically that the plantar fascia runs from the base of the calcaneus, the tibial tubercle, runs up to the forefoot and splits into the 5 metatarsal areas like this. Now, if you're in bed like this, the plantar fascia is much like a bowstring. There's your bow, and the fascia forms the bowstring. As soon as you get up in the morning, you put all your weight on your foot tends to pronate excessively due to the nature versus civilization aspect, and when you collapse the mid-tarsal area due to excess pronation, it creates a massive force over the origin of the plantar fascia. If you look at the foot, you'll see most of the weight runs over this rear section. So you get the detachment at the heel, not in the middle of the foot or in the front of the foot.
Attractional force you're talking about.
Exactly. So you sit down, your foot is relaxed, you stand up, bang. And the trick is here, is when you stand up in the morning or you get out of bed, I caution patients to get out of bed very slowly because as soon as you get that pain, you've ruptured microscopically the plantar fascia. You get bleeding into that area, and then later on, you're not breaking the cycle. So what I advise is the use of an orthotic, or even better, a sandal beside the bed, an ortho-heel sandal, say, or some product that is orthotic in respect so that you don't get out, collapse the foot, and create that chain reaction day by day.
Okay. Now, there's other types of heel pain as well, not just the plantar heel pain that we talked about, but commonly heel pain at the back of the heel. Can you tell us a little bit
about that? Okay. This can occur, well, pain in the back can be anything from Achilles tendonitis to, in younger children, to Sever's disease, which is a growth plate problem. Probably the most common thing is the Achilles tendonitis, and the two can be confused. Sometimes if you look at the Achilles tendon, which runs from the back of the leg down into the back of the calcaneus, it's very close to the plantar fascia. So you've got the insertion into this part of the heel and the plantar fascia here. So some people can get confused, or patients can, with defining where the pain is occurring. With adults, generally we find with the excess pronation, you have a lot of rotational forces in the rear foot, and with the calf muscles designed to contract and increase your propulsive phase mechanism, if you pronate and start to collapse your arch, you get a lot of increased rotation around the middle area of this tendo-Achilles area. You get an inflammation, and then you get a strain, which obviously can be reduced by traditional medical methods. But in this case, as a podiatrist, I use the adjunct orthotic to remove this excess frontal plane motion to allow a normal propulsive phase of gait. As in children, the same thing happens with them too. You have an epiphyseal plate here. You may have children anywhere from 8 to 12 years of age who are exercising at a high rate. A lot of pronation due to the hard, flat ground, and this can become detached, and obviously you get the pain. Some practitioners recommend rest, but if you have a cause, whether it's tight musculature, posterior crural, combined with excess pronation or supination for that matter, you should be treating these related symptoms as well as causes.
Okay, so essentially you're saying if there's an excess pronation component there, you know, it's fundamental that that's dealt with in line with other management techniques.
Exactly. Simply telling a patient to rest, that's, to me, is like saying, okay, my car's got bad wheel alignment, don't drive it. Okay. So leaving it in the garage is useless. You should look at the patient, look at it holistically. And again, let me say I'm talking from a podiatrist and my view in regards to orthotic therapy, but stretching regimes, anti-inflammatory, rest to a certain degree as well, but also the use of an orthotic if the diagnostic tests show that you need it.
Okay.
Okay, as you can see in this case, a person suffering from heel pain commonly has a foot that appears to be very flat, but the hard flat ground causes the foot to collapse downwards and out. Now, if we reposition the foot to its natural position and neutral position, you see the arch increases, and that takes the strain off the bowstring, which is the tissue that runs across the base of the foot from the heel to the front of the foot. Conversely, if we let the foot relax, it flattens, it stretches this tissue, which is causing the common pain under the heel that we get with this heel pain condition.
Phil, according to the American Podiatric Medical Association, heel pain is the #1 foot pathology affecting millions of people worldwide every year. Can you tell us a little bit about heel pain and how you treat heel pain?
Okay. As you said, Bruce, heel pain is very common. Basically, I would see this on a daily basis, and there was a common thread of symptoms that would occur. Normally, the patient would come in and say, I've been getting this pain when I get out of bed, or after I've been sitting for a long period of time, then standing up. And what happened with the first instance, a person would be lying in bed all night in a very relaxed state. The arch was in a very upward position, no pressure on the foot. They'd suddenly get out of bed and get this sharp piercing pain right underneath the calcaneus or the heel area. They'd say it was like a stone bruise, and they'd hobble around for a few minutes, whether it was going to the bathroom or basically getting up in the morning to get ready for work, and then the pain would dissipate. Now, if they sat down for many hours and tried to get up, the same cycle would occur. And as a practitioner, we diagnose that as plantar fasciitis, which is inflammation of the plantar fascia. Well, if you study the foot, Bruce, and where the plantar fascia arises from and inserts into, the base of the calcaneus or the calcaneal tubercle is where it arises from. And it splits into 5 sections, into the 1st to the 5th metatarsals. Now, what happens is people say, well, I understand if a person stands on their feet and they're pronating due to the hard, flat ground, as we explained earlier, but why doesn't it cause a rupturing or an inflammatory process in the centre of the foot? Firstly, if you look at the weight of the body, it originates over the rear of the foot. The upper body is here, the weight is coming right over this area. So as soon as you load this area, you get a tension or a traction at the base of the plantar fascia, which is where normally we get the inflammatory process.
Okay, so how does plantar fasciitis differ from the heel spur?
Okay, good question. A lot of people will have x-rays taken and say, I've got this spur formation here. Many doctors have been known to say this is the cause of the problem, but in actual fact, a heel spur is a compensation, which normally occurs after a long period of suffering from plantar fasciitis. Now, what happens is, over time, as the plantar fascia detaches from the calcaneal tuberosity, you get an ossification or a buildup of bony substance that runs in the line of the plantar fascia. If you have an x-ray, it looks like actually a point. But if you turn the foot over, it's generally as broad as the base of the calcaneus itself. So in actual fact, removing a spur or something like that is just not necessary, because it's a compensation for the plantar fasciitis, and we treat the spur similarly as we do plantar fasciitis by re-correcting the foot, having the arch increase in height, and we take the strain off the plantar fasciitis, and that takes away the cause here. Okay. In this case, we see a patient who generally is suffering from plantar fasciitis, and as you can see, the foot appears to be very low in the arch area and elongated. At the same time, the foot is heavily pronating, and if we reposition the foot to the subtalar neutral, which is this position, you'll see the arch increases in height, which reduces the strain across the plantar fascia region. Now, if we lift the foot up and look at the foot at the base, it reduces the strain. And actually, you can look at the arch here, it's incredible. It's come right back up. So you can see, if we dorsiflex the toes, the region of the plantar fascia, you can see it here, but the main area of force or rupturing is right back here in the medial edge, and we can see this if the person puts their foot on the ground and just relaxes, the foot pronates. Conversely, if we bring it back to subtalar neutral, the arch comes up, taking the strain right off that plantar fascia region and reducing the inflammatory processes and pain.